Good afternoon, everybody. My name is Greg Howe. I'm with the Center for Healthcare Strategies. Welcome to our webinar on using telehealth to support equitable access to healthcare in Medicaid. This webinar is part of our learning series, Strengthening Primary Care Through Medicaid Managed Care, which is made possible by the Commonwealth Fund. Next slide. Before we get started, I'd like to quickly go over a few housekeeping items. To eliminate background noise, audio lines are muted for today's event. We will be recording the webinar, which is in progress. There will be a moderated question and answer session during today's presentation later on. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time for how to do that. Also, after the presentation, there will be a brief online evaluation that will be popping up on your screen following the event. Your feedback is very important to us, and we hope you'll take a moment to complete that survey. Next slide. So we have a very straightforward agenda today. After my introductory comments, I'll introduce the panelists. Each panelist will provide a short presentation, which will then be followed by a moderated discussion. We'll then open up for a question and answer from the audience, which will be through that feature that I mentioned a minute ago. Next slide. Actually, you can skip the next one. There you go. Thank you. For those of you who are not familiar with the Center for Healthcare Strategies, we are a nonprofit policy design and implementation partner dedicated to strengthening the U.S. healthcare system to ensure better, more equitable outcomes, particularly for people served by Medicaid. Next slide. And also, before we get started, I wanted to point out to you our toolkit, Advancing Primary Care Innovation in Medicaid Managed Care, which provides guidance for states interested in exploring the topics we'll cover today, and as in other webinars that are part of this series. Next slide. So during the series so far, we've already covered a number of topics that are actually checked here. You can see those topics. Some of those topics include enhancing team-based care, integrating behavioral health care, and identifying and addressing social needs, as well as some other topics. You can find recordings of those webinars on our website, chcs.org. This webinar will also be made available as a recording too. So today, we will be talking about using technology to improve access to care. This panel discussion, which is made possible by the Commonwealth Fund, will explore policy and practice level strategies to increase access to telehealth for people who face challenges getting to a provider's office, including patients in rural and frontier areas and individuals living in under-resourced communities. All right, next slide. All right, let's get to the main event. We are very pleased and grateful to have 4 great panelists today, and I want to introduce them to you all. I'll do introductions for all 4 panelists first, and then I'll turn it over to our first presenter. And again, each panelist will give a presentation, and then we'll follow that up with some moderated discussion, and then the Q&A will follow that as well. Dr. Sachin Shah is a primary care physician working on the south side of Chicago with interest in healthcare delivery innovation and equity. He is board certified in internal medicine, pediatrics, and clinical informatics, and serves as Chief Medical Information Officer of the University of Chicago Medicine and Biological Sciences, where his work focuses on patient engagement, digital transformation, population health, and clinical analytics. Jennifer Azara is the Senior Director for Performance Improvement and Organizational Development at Community Care Cooperative, which is a mass health accountable care organization. In this role, Jenny is responsible for designing and implementing initiatives with participating federally qualified health centers to achieve goals for quality care and total cost of care. This work includes leading the organization's strategies to advance telehealth maturity and to improve patient experience. Jenny also provides organizational leadership for developing C3's culture by developing strategies and methods for employee engagement. Dr. Chelsea Bodnar is the CEO of Montana Pediatrics, a 501c3 and technology-enabled collaborative of Montana-based pediatric providers that is committed to improving health equity and care access for children across Montana. Dr. Bodnar is working to improve the pediatric care model on a large scale by leveraging technology to foster collaboration among providers and families. A Rhodes Scholar, Dr. Bodnar was also a clinical scholar with the Robert Wood Johnson Foundation and an American Academy of Pediatrics Leadership Fellow. She has served as a health policy fellow at the Institute of Medicine, director of children's healthcare quality at a large consortium of Fqhcs, a primary care physician for children in a wide range of care settings, and currently serves on the executive committee of the AAP section on telemedicine, among other regional boards and committees. Dr. Christopher Chen is a medical director for Medicaid at the Washington State Healthcare Authority. Dr. Chen is dedicated to serving the underserved and believes in the HCA's mission to use innovative policies and purchasing strategies to improve health and address disparities. He helps guide clinical policy and strategy at the agency and supports initiatives in health information technology, telehealth, quality, and health equity. He previously served as the medical director of value management and associate medical director of hospital medicine at the University of Washington Medicine Valley Medical Center. Thank you so much to all of you for participating in this panel, and let's start with Dr. Shaw.
Good afternoon. Thank you so much for the invitation. I think I'm going to have control of the screen here. I'm going to just quickly go through a couple high-level points to set the table for some of the discussion. You know, the quick first point is that we can do telehealth. We have been ready for a long time, and you know, the circumstances finally aligned to let us do it. There were all these sort of much ballyhooed, you know, barriers that, you know, we were always kind of told were going to be problematic, but these barriers have all proven insurmountable. The real key factor, you know, when the pandemic arrived just over 2 years ago was the economic, you know, incentives, which was reimbursement, and combining that with, you know, the need for safety and the stay-at-home orders, it became very clear very quickly that we could do this, and we have been. You know, the you know, this figure here that looks a lot like, you know, the figures that many of us in our practices across the country sort of faced around, you know, how little, how quickly, you know, our ambulatory volumes cratered in the face of the pandemic, and how quickly we were able to pivot to telehealth. You know, is emblematic of how quickly we could make that that shift. You know, we did 120,000 virtual visits in the first 6 months. You know, it was, after even a year, it was still, virtual care represented over a quarter of all of our visits, you know, and still over 20% after the first year and a half. And 3/4 of all those visits were video visits. You know, patients like telehealth. That's the other thing we've learned, you know, very quickly. They have their priorities of safety, convenience, timely care, and telehealth can really reduce certain barriers to care. Patients don't have to deal with transportation issues. They don't have to deal with child or elder care. Sometimes it can really limit the time they have to take off of work, and it helps families and caregivers be more engaged in their care. You know, I wanted to, you know, sort of transition to the equity piece, because, you know, it reduces some barriers, as we all know, but it also introduces, you know, many others. And that's where I think the focus of a lot of our discussion today will land. You know, the three kind of big buckets that I think a lot of us think about in terms of barriers are, you know, the absence of technology, low digital literacy, and broadband access. And the groups that face this most acutely are, you know, predictable. You know, they're some of our most vulnerable populations. They're older, they have lower socioeconomic status, they're members of minority racial groups, lower levels of education, and non-native English speakers. We also know that video visits are better than telephone visits. You know, the slide will be in the deck for reference. I won't spend a lot of time. But we also know that those patients in those vulnerable populations struggle with barriers in each of those three buckets that I mentioned. And this is all data, you know, from, you know, middle of the pandemic. It doesn't actually predate the pandemic. And we also know that you know, some of these barriers they don't just have implications for healthcare. They have implications that are, that cut across all sort of sectors. And we should think about broadband access and digital literacy as a social determinant of health. And so I wanted to spend the rest of the minute and a half that I sort of have left here focusing specifically on the south side of Chicago where I work as a primary care physician. And it's an area that is, has patients with pretty low socioeconomic status. It's in the middle of, some medical and pharmacy deserts. There's a lot of, pockets where there just isn't good broadband access and healthcare infrastructure in general. When we look at our sort of looking at virtual care and access, when we look at our, the first year of the pandemic, overall volumes of video visits and telephone visits, you can see that and sort of the breakdown overall. 80% of our patients could do video visits, and 20% had to focus on telephone only visits, which seems like a reasonable percentage. But when we start looking at this through an equity lens, we see a lot of more important sort of insights come. So white patients were able to do about 85% of them were able to do video visits versus 15 that were focused on telephone visits. Black patients, you see there's a disparity that starts to emerge. 10% of them were less able to do video visits. And then when you start stacking some of these risk factors, we see that if you're Black and live on the south side of Chicago, it's more like a 70-30 switch. When we look just at age independently, it's more like 65-35 for our older patients. And then when you stack all of these risk factors together, Black, 65 and older, and on the south side of Chicago, we saw that less than half of our patients could participate in video visits. I'd love to say that this improved over the course of the pandemic, but this was data for the June to January period, and it really just simply didn't. And so this map here, the patients on the south side of Chicago and in countless other places around the country, rural and urban areas, the same ones who experience worse health outcomes and common chronic diseases are the ones that bear the burden and disproportionately experience impaired access to telehealth. So I'll stop there, and thank you again for having me as part of this panel.
Thank you, Dr. Shaw. Really appreciate it. And just to remind folks, we'll have a lot of opportunity for questions a little bit later. Let me now turn to Jenny, and I'll let you take it away.
Thanks, Greg. I'm really grateful to be here today to share the story of what Massachusetts Fqhcs are doing in the telehealth realm. As Greg mentioned, I work for Community Care Cooperative, but I'm here today representing the Fqhc Telehealth Consortium, which is a partnership between Community Care Cooperative and our state primary care association, the Massachusetts League of Community Health Centers. Here's a picture of the consortium. C3, Community Care Cooperative, is also known as C3. We are about 6 years old and have 18 Fqhcs as members in our organization. We started with the Medicaid accountable care organization model, and now are expanding into other value-based payment risk-sharing agreements with other insurers. And you can see the Mass League is a PCA that includes all community health centers. When we started the consortium, we did so because we were raising funds. Folks wanted to support health centers at the onset of the pandemic, and so 35 out of the 37 Fqhcs in the state decided to sign up and benefit from the resources that were coming in. You can see here that the Fqhcs that are participants in the consortium are all over the state, with about 15 of them based in Boston. This is an overview of what we've been doing over the past 2 years. I won't go through every little bubble here. It's all to say that this partnership has brought in about $11.2 million in over 2 years. That's gone directly to the FQHCs in the state in technical support and programs, grant-funded programs that support staff, technical assistance and training. And I will get into some of the details now. And again, you'll get these slides after the presentation. So some of the details of the beginning of our work together in the consortium. Whoops, sorry, that went a little too fast. There we go. In the beginning, we raised funds that really went straight to the health centers for technology support. Some health centers had desktop computers and needed laptops to be able to send their staff and providers home to deliver care safely. Soon after the deployment of technology and IT technical assistance, the CEOs and chief medical officers of these health centers came together to form a long-term strategy for telehealth. Once reimbursement opened up, we felt like, you know, the sky's the limit. So let's plot out a long-term strategy for sustainable, equitable model for telehealth. And we did that with the development of a maturity model. Everything I'm going to talk about today is in a playbook we published. There's a link at the bottom of this slide. Our maturity model also has an associated driver diagram about key drivers of increasing telehealth capabilities in an equitable, sustainable way. With that maturity model, we then assessed all 35 health centers in the state and provided them some tools on how to improve with telehealth. In the second phase of our telehealth work, we launched a pilot program with 9 health centers. We just wrapped that up. We started measuring key performance indicators that included telehealth utilization and select quality measures. And in everything we measure, we include detail about race, ethnicity, and language for both utilization and quality. We received the Fqhc Connected Care Award to improve broadband at our health centers and with select patients. We published our playbook, which I already mentioned. And what I really want to share with you today is that we developed a telehealth equity framework and a telehealth navigator program. So our equity framework was developed in partnership with Health Resources in Action. And this was also funded through our Telehealth Transformation Initiative, our pilot program with 9 health centers. And I'm really proud to say that we were able to get patient partners to the table to help us develop this equity framework. The framework mirrors our maturity model and it's in the playbook. So if you can see strategies in there, really concrete tactics that get at making sure that patients are not left behind by advancements in telehealth. One of the key tactics outlined in our framework is and this is our framework, which I will skip over now, is the Telehealth Navigator program. And the Telehealth Navigator you can think of as an upskilled community health worker, someone who is going to be patient-facing, helping address those digital barriers that have already been mentioned, broadband, devices, literacy, and can help patients understand how to access services. And 2 health centers, we have them teaching patients on how to use remote patient monitoring. And we have built both within the Navigator program and the larger consortium learning communities so that health centers can learn from each other and that the sharing is spread through our playbook. We have 2 programs right now. One is a telehealth navigator program addressing hypertension, and another is a telehealth navigator program in a region of our state, and those navigators are addressing utilization with non-English speaking patients and patients in the behavioral health department. So there was a lot of detail. I really look forward to the panel discussion. Thank you.
Great, Jenny. Thanks so much. Let's turn to Dr. Bodnar now.
Thanks. It's so fun to be here. And I already have a lot of questions for the first 2 presenters, but I don't think I'm allowed to ask them yet. So I'm going to talk to you a little bit about the work we've been doing in Montana with an organization now called Montana Pediatrics. You can go to the next slide. Just so you guys orient to our community, because I know people from all over the country are here. Montana is a big state, 4th largest in land. I think one of our former senators said there's a lot of dirt between light bulbs. We're 48th in population. And it's striking when you look at the size of these spaces to realize that across the state of Montana, 20 of our 56 counties don't have a single provider who is specifically pediatric trained. And 15 don't have a single medical provider or didn't at the time of this snapshot. So you can go to the next slide. That's just a bit of context. And so Montana Pediatrics, I just want to tell you about, because we're kind of a harder to understand than an established Medicaid organization. We're very grassroots and are a social innovation organization that drew out of the communities that we serve, both, and we think of our primary community that we serve as, of course, our families and our patients, but secondarily, the workforce of rural America and Montana. And we think that it is in the best interest of everyone that we think about solutions that both address workforce as well as families. So our model is to build virtual communities of pediatricians who bridge competitive health system boundaries to serve, to reboot our perspective of who we serve, to be not just those who can come sit in our office, but all 256,000 kids of the state of Montana. And right now we have 36 active providers. In Montana, we only have between 100 and 120 pediatric providers, but they represent 19 different technologically and administratively and competitively divided systems. Next slide. So our approach is to sort of ask ourselves, where are the gaps and how can we work together to harness technology and our latent capacity to fill them? So I'm going to talk to you just quickly about 4 of those exciting places that we've been able to take our core principles, listen to the community, and adapt our skill sets for them. So we're going to talk quickly about the after-hours space, which is not a pain point only in Montana or rural areas. We're going to talk about our work in the Fort Peck community, and we have growing work with American Indian communities, both rural and urban, and children with medical complexity who face a real gauntlet in Montana of coordinating their care and even getting care within the state boundaries. And then children in crisis or transition, some other places we've specifically focused. Next slide. So our after hours model is a completely collaborative model across the state of Montana that we developed to strengthen the capacity to provide care in this space. It's all entirely locally driven. We work by, with, and through whatever version of a medical home is available in a community to create essentially a telemedicine shared call pool across the state in order to create continuity at scale and to make sure that as patients move towards the convenience revolution and a growing sense of on-demand capacity in healthcare, that we are making sure that it is providers who know the community, who value this place, who understand what it means to have a child, a 2-month-old who's sick in a tiny little town in Montana and can provide valuable care, are going to be the ones who respond to those on-demand services. So we're now open all night and all weekend, 365 days a year, regardless of the ability to pay. And we do take all insurances. So after hours is a place where we're seeing that we can both get every 4th pediatrician off of their couch from taking phone calls at night, and we can improve dramatically the access that families have when they're with their kiddos and not necessarily just during the day. So next slide, please, Travis. Thank you. The Fort Peck Reservation is the place that we have been working with for several years. There is a tribal health program there that had been has an incredible amount of work done on school-based health centers. But of course, the challenge was how do you get providers specific to this setting to come and stay with any degree of continuity? And so we're now going into our 3rd year of full-time support for the 6 school-based health clinics there. This is an amazing story as we get into questions about, we don't always have the same, Jenny has such great, toolkits and great language that I need to learn to apply to our work, but this is in conjunction with, oftentimes our telepresenters went through a 6-week CNA course, just graduated from high school, have never thought of themselves as interacting with the healthcare system. And we get to work closely with them. And I think the growth bi-directionally is incredible. And it's one of these places where telemedicine serves much more than just a spoken hub access to a doctor. Kind of cool when you think about the scale. as of when we were creating these slides, if we estimated the number of miles those families would have driven on icy Montana roads to get the care, we're creeping up on 450,000 less miles driven. So when we think about impact on families, those are some of the fun ones. Next slide, please. Children with medical complexity, we are working on what can we do to pull up alongside those who care for children across the state and offer a virtual support structure for shared plans of care and the capacity to navigate inevitably several health systems with disparate EHRs, and most often families that actually have to travel out of state and return to Montana, who struggle very much to and are very much burdened to pull that all together. And something we think telemedicine and virtual care and collaboration is uniquely able to solve. So we are in the midst of beginning to do care planning with families across the state. And so they have a cloud-based shared plan of care, as well as an owner of that. We can talk more about that. And we're really grateful to the Helmsley Charitable Trust and the University of Montana. We're now launching a 2-year effort to develop a statewide care model stretching from schools clear through on-demand subspecialty access for all of the children in Montana with type 1 diabetes. Next slide, please. I am a minute over. The last place that I'll just say is we're also working in homeless shelters, families experiencing homelessness, domestic violence shelters, as well as with communities of especially vulnerable communities, young moms who are in crisis and have children. We have worked from them as the starting point out to create access points that are specifically for them. It helps us sort of reverse that play that we look at when we see the data of if you launch telemedicine out for the world, we see that vulnerable populations are less likely to access it. We've worked on sort of starting in these settings and deliberately creating the systems for them so that they are most accessible to those communities. Next slide. So I think the quick points I would leave you with from our sort of unique experience here is that we think that telehealth can be something that actually can decrease cultural barriers and health equity and increase health equity inequities. You know what I mean? Trying to go fast. We think it is an incredible opportunity, despite the initial sense that this is removed or that this is less personal, to actually create greater sustained culturally effective partnerships, because it doesn't require the geographic constraints that we see for some of our rural communities who have a revolving door of providers. And we really do think it can be a low barrier addition to primary care, as well as a way to weave together primary care workforces in a way that we haven't spent much time imagining in the past. Thank you.
Great. Thank you very much, Dr. Bodnar. Let's turn to Dr. Chen.
Hey, Greg. Thanks so much for having me today, and thanks so much for those fantastic presentations. So I'll just briefly share a little bit about our state perspective, if that's all right, Greg. I work as a medical director for Medicaid at the Washington State Healthcare Authority. On the next slide here, I can tell you a little bit about the Healthcare Authority. We are Washington State's largest healthcare purchaser. So we serve as both a Medicaid agency as well as an agency purchasing on behalf of a public employee program. And so that's about more than 2.5 million residents at this point, probably closer to 2.8. Under Apple Health, which is our Medicaid program, we have about 2.2 million folks enrolled as of April 2022. And that's been increasing through the pandemic as a result of some of the economic fallout. We very much on board and aligned with the speakers here today in terms of harnessing technology and telehealth for the purposes of serving the underserved and the vulnerable. And so on the next slide here, just have a little bit of a summary of our telehealth journey. And if you wouldn't mind just clicking through these bullets. pre-pandemic, our Medicaid telehealth policy was actually relatively broad. This was a pretty broadly flexible policy that was applicable to many different types of services and providers in different settings. And here in Washington, we covered telemedicine as defined as real-time audiovisual services and had parity in place since 2018 as well, and also covered e-consults, also known as stored, forward, and specific specialties. And I think kind of interestingly, we even despite the broadly flexible policies that we had, did not see significant amounts of utilization, and through the pandemic saw some of the shifts that Dr. Shah outlined in some of his graphs, and just at least here in Washington, we saw it over 30 times increase in the utilization of telehealth, and I think that really speaks to the need for policies to be in place for certain, but also for the clinical workflows to change at the provider level in adaptation. I think that's the theme that we saw among many of the speakers today in terms of the need for rapid change and adaptation. In response to the pandemic, kind of additionally, on top of those policies, we also made additional policy changes to support the continuity of care. And so, as many did, allowance of non-HIPAA compliant audiovisual and audio-only services, as well as additional coverage of patient portal, virtual check-in, remote patient monitoring services. We also felt the need to more directly provide support for both providers and clients. So we purchased and distributed 2,000 free Zoom telehealth licenses to providers serving the most vulnerable. And this again was at a time back in March, April 2020 when providers, I think many were supported by large organizations with the infrastructure to help them make that shift to a telehealth modality, but especially the providers that we work with in Medicaid, many were smaller practices, potentially independent, who didn't have that kind of support, and we wanted to make sure that there are ways for them to communicate with their clients in a HIPAA compliant way, and a Zoom license was a pretty easy way to do that. And additionally, we also provided hardware assistance program that distributed smartphones and laptops. And we collaborate with partners in telehealth as well. And so worked with the UW Behavioral Health Institute to provide technical assistance for providers. How do you adopt website manner practices? What does consent look like over audiovisual technologies? All those kinds of, how do you code and bill for services? So all those kinds of nitty-gritty details in making that shift to telehealth. And we also collaborate with our broadband access partners, including our Office of Broadband here in Washington, as well as other federal initiatives to try and address that digital divide that was previously mentioned, knowing that many of our clients do face barriers to care. So next slide. I think this is, and then the presentation generally has kind of been a reminder for me that telehealth and technology is a tool, but is not a goal in itself. And our tools and modalities might change, but the goals don't. And so I think things that we strive for both in and out of telehealth follow some of these general principles. And this was a framework that was developed by the West Coast Compact between 5 states that kind of organized around a couple of different high priority strategic initiatives through the pandemic. And I thought the framework was helpful and relevant. And so just wanted to share some of the important goals in terms of preserving access, maintaining confidentiality, really striving to continually achieve equity and close gaps, maintaining high standards of care, ensuring quality of care, as well as thinking carefully about stewardship. And I think stewardship especially is a principle that many folks have kind of gotten used to in different ways through the pandemic, right? And I think go to grocery stores and sometimes shelves are still empty from certain supplies, and we've very much experienced different scarcity of resources in different ways through the pandemic. And I think if we take a step back, scarcity is something that happens both in and out of the pandemic, and it was especially in Medicaid, where we often operate with limited funding, thinking about how do we kind of best allocate the limited resources that we have to achieve the greatest health outcomes for our population. Preserving patient choice, I think, particularly important in equity, as well as thinking about the payment and reimbursement considerations that support all of the goals. So yeah, I think those are the slides that I had, and glad to be part of this webinar today.
Great, thank you, Dr. Chen, for that presentation and sharing what you're working on in Washington. And so we're going to switch to the moderated discussion part of the webinar, and I want to start with Dr. Chen and ask if you could provide some kind of some reflection on some of the presentations that you've heard today, particularly around providers and how to support providers from a state Medicaid perspective.
Great, thanks so much, Greg. Yeah, I think so really honored to be part of this panel today. I think you had a great representation of different parts of the ecosystem, and we heard from health system, federally qualified health centers, rural perspectives, and some common themes that we heard were just the need for rapid change and adaptation, as well as a dedication to serving the vulnerable and the disadvantaged. And I just so appreciate that, because I think oftentimes we in the general telehealth conversations kind of are so focused on innovating that we forget about who we might be leaving behind. And I think that this group of people here today is particularly focused on that, and that's very much appreciated. And I think from the state perspective, healthcare is crazy complex in America, and I think we all have a different lens of this prism. And from the state perspective, we often see, we hear the perspective of not just providers, but also of clients, other state agencies, communities, our federal partners, as well as some of our contracted managed care organizations. And I think, and certainly trying to mobilize everyone together for achieving the common goal can be difficult. But in general, just, very much appreciate the focus on innovating in the name of serving the underserved.
Great, thank you. I want to open up to the rest of the panelists, and I want to start by reflecting on the patient perspective. And I know some of you touched on this and wanted to ask you around the area of building trust. How do you build trust with patients around telehealth? And I want to start with Dr. Shah, because I know you've done some work on understanding the patient perspective, and would really like to hear your thoughts on how you went about that and some of the ideas you have to provide additional support to patients and providers.
Yeah, I think that's an absolutely essential part. I mean, we can sit in our practices and sort of think about what we think patients want and what we think the barriers are, but we're not really going to truly understand unless we're actually there in the communities with them, partnering with the community-based organizations, learning from these needs assessments and surveys. And we've done a lot of that work on the south side of Chicago. We've leveraged a lot of our existing partnerships. As a primary care physician myself, we're constantly talking to our patients and trying to understand their perspective, and that's got to really inform the steps that we take to help kind of close these to work towards bridging at least the divide. So for us, it translated to things like Jenny highlighted this nicely in terms of the digital patient navigation piece, and it doesn't take a lot. It takes some basic digital navigation. It doesn't take a net new role. It takes a skill set to train up to. We found the very same thing that was highlighted there. That goes an incredibly long way. We've focused a lot of our advocacy efforts on the lessons we've learned from these conversations. And one of the most important ones is that we need to keep reimbursing telephone visits. This shift to restricting, reimbursement to only behavioral health telephone visits, while important, we need it for things like chronic disease management. We need it for, check-ins, for, for all sorts of other things. It's not perfect for everything, but it provides a ton of value. And it's the bridge for many of our patients who otherwise lack access. And, the numbers that I showed you in my slide set, I think, are emblematic of many places across the country. So there's some basic ones, and then the other piece is around the user interface. I mean, Chris just mentioned this. He articulated this nicely, but I mean, we have to stop innovating. We really have to push our partners to stop innovating exclusively for the most connected and digitally literate and well-off individuals. Skimming from the top, if you will. That's easy, and that's what everyone's been doing for a long time in this space. I think it's on us to really demand that we focus on, frankly, our Medicare and Medicaid beneficiaries. Those are the populations that bear disproportionately the burdens of, chronic disease and health disparities in our country, and they're the ones that could benefit the most from this type of innovation in this space. And those are the ones that we have to demand get the attention that has been missing for a long time.
Great, thank you. Dr. Bodnar, I wanted to ask you about the same question around building trust. I know you've done some important work in that area, and it'd be great to hear more about that.
Yeah, I think it's always, I love thinking, telehealth is a tool, right? It's not an end point. And so we don't, you said that perfectly. So we don't build trust to get people to use telehealth, right? We use telehealth to reach people who otherwise couldn't be reached, to show up and be present when we otherwise couldn't be present. And that, I think, across humanity is how we build trust. And so I love certainly barriers. And so all of the trust building, listening issues apply to telehealth just like they do to the rest of medicine. Absolutely no difference, right? We owe our patients that type of deep connection. But I think what's interesting is how we've been able to use telehealth to create trust in communities who otherwise don't have trust in the healthcare system. And one of those examples that I think is really moving is a community here that is young moms in crisis, under 21, pregnant or with children, and a place called the Mountain Home that provides wraparound services for those young moms. And when we went to listen to those moms about what it is that their experience with healthcare was, they said, well, let me tell you about it. I'm supposed to be in treatment programs in the evening. My kid gets sick. I take him to the ER. They're across the street from an emergency room, so not a likely telehealth setting. They go to the emergency room. They feel shamed because they're bringing a low acuity issue to a high acuity location, and many of them have CPS involvement, so they get treated with suspicion. They go back, they have built no trust in their healthcare system. They're told to see their primary care doctor. Their primary care doctor can see them at 2 o'clock next Tuesday, when again, they're supposed to be somewhere else in order to get themselves back on their feet. So they don't take their kids for care, and then they get accused of being neglectful. That is the cycle that telehealth and after hours access can break. And that's when we start to earn the trust in the healthcare system that I think we have lost by being not accessible to people. So I guess when I think about trust in telehealth, I think it is an incredible opportunity. And that's how I would approach it.
Thank you. Jenny, with the Navigators program, I imagine trust is a big part of that program as well. Can you talk a little bit about how that is sort of woven into the work that you do there?
Sure. So, well, I think folks want real transparency about what the options are for getting care, and then choice. And providers, meaning, clinics, health centers, doctors' offices, they aren't always really clear about what the choices are. And sometimes patients may feel like, oh, I'm getting this type of service because of who I'm perceived to be. And so I think for, not just navigators or providers, but for, systems, real transparency about what we offer, how you choose, and that it's all excellent care, that virtual care options complement in person and will work with you to find the best option. What the Navigator program offers, or any position, right? It doesn't have to be this type of program, but any additional, unlicensed, non-revenue generating staff person, which are, those are not always funded in all practices, but what these positions can offer time with patients and families to understand their needs. That's trust building, right? What Chelsea was just saying about listening. Understand, guide them to low-cost broadband programs if they don't have reliable internet, help them how to use the different technologies that are available. It's time, and it's partnering with the whole care team to make that happen and to build that trust. Just like care coordination, these navigators are the glue in helping patients and families understand what do I need when and how. I hope that's helpful. And what we've learned is that there's so many new workflows that are needed since the onset of the pandemic and the integration of telehealth and primary care and behavioral health, and that you cannot underestimate how much time a practice needs to spend on building these new job descriptions, new roles, and workflows, because we lose our patients' trust when we're not all on the same page and they get bounced around a lot.
Great, thank you. I want to shift now to the questions. I mean, I have a ton more questions I could ask you all for this discussion, but I want to make sure that we have a chance for participants to ask questions, and we have some good questions that are coming through. So let me just shift to the first one, which this is, and you all touched on this, and Jenny, especially in your last comment, but has the adoption of telehealth in your practices changed the way your providers engage with patients? Has it improved care management, care coordination? Are providers able to provide better tailored care, meet the patient where they are at? Dr. Shaw, do you want to start with that one?
Yeah, I'd say that it's a work in progress. I think a lot of us see the potential of this, and I think we've made some fitful progress on this front. But the way I think about it is, it gives us a real opportunity, and we've had some success with this, and in some areas where we still need to make quite a bit of progress. But it helps us match. Our patients are different; their needs are different. It helps us connect, the right patient with the right sort of channel or mode of care. And so that can mean, synchronous versus asynchronous. That can mean in-person versus virtual. That can mean, getting, some level of healthcare based on acuity and complexity from a provider versus an MA versus a community health worker versus an RN. And then it helps us kind of also differentiate between stable chronic disease management and more active sort of urgent, needs versus, procedural, needs, which have to be in person. So, we've had this sort of one size fits all approach for a long time, which is you come to the office and you get the care that you need. When in reality, some of that care is, a repeat blood pressure, which you could do with a remote patient monitoring device that that can be easily transmitted, and you can have a phone call to say, okay, let's make this adjustment, or it could be you send a message through your patient portal, and an RN responds to it, and refills the medication that they're requesting. There's a lot of matching that can happen that serves the patients much better. It gives them a better experience. It helps in terms of access for our providers and our practices by offloading some of the unnecessary stuff, and it actually benefits both the patient experience and the practice and provider care team side with access and the burdens. Are we all the way there? Absolutely not, and it does require sort of a lot of work, as we've kind of referenced earlier around reorganizing our workflows and reorganizing our workforce, and that's what I mean by it's a work in progress. But there's again, if we support this the right way, it's a really powerful potential way to transform the way we deliver healthcare in a way that benefits everyone.
Okay, thank you, Dr. Bodnar. Thoughts on that question?
Yeah, I love the first part of the question asked about how our providers have engaged with patients. And the first image that popped into my mind, which we could take or leave as useful, is one of the pediatricians who is really active with our work. He's actually our state AAP president. does all of his after hours work with his cat with him. and we get this feedback from families that they were home and worried, and Dr. Cole was there in his home with his, so yes, it has changed some of the ways that our providers feel like they can engage. I think care coordination and case management, all of the things that have been mentioned, the promise of remote patient monitoring, of using cloud-based technologies to transcend traditional boundaries, to make the patient entry point a single one and put it on us to navigate, get them navigated virtually to the correct place. We have not accomplished all of that, but I have whiteboards full of ways that it is now possible to do that in a way that geographically constrained healthcare never could have imagined. So we don't have the proof, but we have the vision and we have the tools. And so it is very exciting.
Great, thank you. Jenny, additional thoughts on that? I know you touched on that earlier.
I don't know how to add to the previous comments, but we see, patients engaging with providers in ways that we couldn't have imagined. And part of it is us being really proactive. When I say us, I'm speaking on behalf of all the good work at the health centers. I am not working in a health center, so I want to make sure folks get the credit. But we have health centers who we've been able to fund to do some enhanced population health management and connect patients with providers. They haven't gotten care perhaps in the past 2 years during the pandemic by running lists. One health centers run a list of patients who haven't been in 18 to 24 months, whose last blood pressure reading in the EHR was high with an or diagnosis of hypertension. Having staff get those folks in and connect with providers, and just getting back to the trust question, staff are doing that by reaching out, listening to patients, checking in, see how they're doing, also addressing their social health needs, and then being able to bring them back in for needed in-person care. So folks have interacted with their providers in all sorts of ways. And just a personal story, I was at my in-laws the other day, and my father-in-law had a Bluetooth scale, Bluetooth pulse oximeter, and Bluetooth blood pressure device, which he all demonstrated for me, that's being managed by the VNA. So I, see it, across the board, all ages, all languages. Since someone brought up the, portal use, I do want to add that one way that providers could better interact with their patients through virtual cares, if portals were in many languages. We see that as a big barrier to gaining trust with our patients, is having barriers for them to be able to access telehealth visits, and telehealth platforms that go through patient portals that are English and maybe only Spanish create a huge barrier. So I just wanted to put a plug in for that.
Thank you. I'm glad you raised that. And I wanted to also, and I know we've touched on this a little bit, but just if you could talk a little bit more for patients who don't have access to technologies, or are there other technologies? I know, Dr. Shaw, you talked about telephone visits and the importance of those, but are there other ways that we're not thinking about? We're not talking about technology that could be useful for hard to reach folks. And let me start with Dr. Shaw.
Yeah, I think we've talked about technology as sort of an extender and not a goal in and of itself. And it doesn't have to be high tech, right? I mean, it's a way to reach our patients where they are with the resources that they do have, and understanding that many of them don't have all the resources that that some of our well-off patients have. So I do, telephone and text messaging are the two that I think are relatively ubiquitous, and that we can, that I think those two things are ways that we can really leverage, some of the things that most of our patients have access to. I can't stress enough the importance of telephone, visits for reaching our patients. It was an absolute lifeline, especially, in the first months of the pandemic for so many of my own patients personally, and for our health systems patients, who needed ongoing care and active management for many things. And then, on the digital navigation piece, again, it doesn't have to be high tech, but if you can text, a link or a phone number directly, to your patient in time, like at the time of their appointment, that actually is remarkably effective at getting them, onto their visit, whether it's a telephone visit or, if they have a smartphone, a video visit. And those two are small, they seem small and they seem minor, but the access that actually gives and brings I can't understate how important those are.
Great, thanks. Jenny, your thoughts on that?
I got lost in listening. What was your original question?
So just thinking about other technologies, or for folks that don't have access to technology, are there other ways to reach
Sure.
those folks? And I know that's part of the work that you're doing, but any additional thoughts on that?
In addition to what I've already said, I would say that we see some FQHCs setting up telehealth rooms or pods within their facilities, so that patients can come in, community members can come in and use that space, that computer, that internet access to have a visit with a provider at a different location, or a specialist, or someone who works at that health center but is doing remote work that day. So offering those spaces, libraries, it's going outside the healthcare space. And in the state of Massachusetts, there are some digital equity coalitions across the state of different organizations coming together to say, how can we expand broadband and make sure that everyone can get access? And then, as I said before, on the patient-to-patient level, it's just listening to their concerns. Sometimes it's starting with dealing with their housing concerns, then getting to broadband and a device. And we just start with where the patient is at.
Great, thanks. Dr. Bodnar, I want to get your thoughts on this question as well, how to reach and how to support patients with limited telehealth capabilities. And I know you've touched on that a little bit. And then I'm gonna go to Dr. Chen for the final comment. But let me go back to you, Dr. Bodnar.
Well, I thought what I would do is just demonstrate some technological challenges for everyone here while we were talking, to just, exude empathy. My computer actually is having problems right now, very unanticipated. So if I disappear, it was lovely to see you all. I think for this, it is just one of these incredible opportunities not to assume that where we sit needs to be adapted for people that have a different experience of electronics in the world. I think it's just really important to decide, who are we here to serve, drop our assumptions, go to the community and sit down and think about, is it Montana? It might be the local bar. 3 hours north of us, it's the Walmart, but there are typically places where the community can gather. There are people who can be trusted, and where these barriers can be overcome to connectivity. Even in probably where we work at Peck is ranked one of the worst connectivity places in the country. So I think the thing is to just, again, switch your mentality, and most places in the world, we can figure out how to get a signal, and we could think about what would be a trusted, safe, secure, accessible point in which to seek healthcare or to get consultation. And then I think if we work out from that, there is no end of possible options to serve these communities.
Great, thank you. Chris, just quickly, we're going to turn to you and give you an opportunity to share your thoughts on some of these points.
Great, thanks, Greg. Yeah, I think all of our panels hit it right on, and I think the thing that really came to mind was that equity is very much a journey, and it's not kind of an endpoint. And although we certainly strive to achieve equity, I think it's kind of an ongoing thing. We need to continually keep asking ourselves, is what we're doing kind of serving the needs of the clients that we serve? Is telehealth reaching them? And to Sachin's point before, I think it offers fantastic ability to kind of customize or connect patients with the right channels of care. And it works great for some folks and it doesn't work well for others. E-consults are fantastic. They've increased patient satisfaction, provider satisfaction, time to specialist consultation. I've seen phone calls work really well, and I've seen some phone calls work not great. And I know of one client who got phone care for 6 months and then was hospitalized for a 10 by 10 centimeter wound that would have been readily apparent on physical exam. And so I think, ultimately, we as an agency, I think we want providers to feel like they have the flexibility to connect with the patients in the way they want, because we don't want to be kind of continuously nickeling and diming providers for our views. If you talk to a patient this way versus you talk to a patient that way, and I think kind of another journey that we're always on is towards value, and thinking about how do value-based payment arrangements facilitate greater quality in care and flexibility in telehealth, and additionally, what kind of data infrastructure do we need to answer these questions? Washington State recently led an application for an audio-only modifier so that we can measure audio-only care and research it and look at the quality. And so I think kind of just continually asking ourselves, are we kind of achieving the goals? And I think the panels today really showed that there's a lot of great work underway to do that.
Great. Thank you very much, all of you. And we're at time, and I wish we had more time to keep this discussion going. But I just wanted to again thank our panel, thank CHS staff that was supporting this webinar, and the Commonwealth Fund, and for all of you who joined today to make this webinar possible. I want to encourage all of you to join us again for our next webinar on May 12th next month, Strengthening Primary Care Through Medicaid Managed Care Series. We will be exploring how different states are working to increase investment in primary care with a guest speaker from Oregon's Medicaid agency. So thanks again, everybody. I hope you have a great day.